TMA's executive. Happy Rare Disease Day, everyone. I'm Paula Eichenbrenner, TMA's Executive Director, and here we are on the last day in February for the TMA, MIHRA, and Nori's Fight We Care for Rare virtual summit. Over the next 2 hours, we're going to celebrate the very best in myositis science, and we're going to hear some really inspiring and powerful patient stories. Thanks for joining us live on Zoom. We also are setting up a YouTube broadcast link. While that's underway, I'll turn it over to TMA's Board of Directors Chair, Laurie Boyer, for the official welcome to today's program. Laurie, over to you.
Good afternoon, everyone. Thank you so much for joining us today. What an exciting day to be together on Rare Disease Day 2025. So we have wonderful organizations that have come together today to make it possible. So I just want to start by saying thank you to the Myositis Association team, the MIHRA team, and Nori's Fight. Without you, this day would not be possible. Next. All right, so we are here for the We Care for the Rare Summit. And when you look at Rare Disease Day, it was actually established in 2008 by Eurodis. And Rare Disease Day takes place on the last day of February each year. And today it's the culmination of Rare Disease Week. So many people have been taking part in lots of great activities this week to elevate the rare patient voice. This slide is a selection of some rare things. So four-leaf clovers are believed to be lucky, as the fourth leaf is the result of a genetic mutation in the plant. In addition, people with naturally ginger hair only actually make up 2% of the world's population, making it a rare hair color. The chances of an all-white peacock being born is 1 in 30,000, making it a rare species of the bird. So like the things in these images, rare diseases are uncommon and hard to find. A disease is rare when it affects fewer than 1 in 2,000 people. Next slide. All the various forms of myositis are rare. Only 50 to 70 out of 100,000 people live with a form of myositis. Myositis is a term for illnesses that involve chronic muscle inflammation. Myositis refers to several different illnesses listed here on the left side of the screen. Myositis diseases are autoimmune in nature, so they are among the nearly 200 autoimmune diseases, and 3/4 of all autoimmune diseases are rare. Due to the wide diversity of myositis types and the presence of relatively common symptoms that can mask one another with the underlying diseases, misdiagnosis is common. Moreover, symptoms not only vary between different forms of myositis, but can also differ among patients with the same condition. So today is a chance to call attention to myositis and to support the families navigating rare medical journeys in myositis, as well as the teams who care for them. Next. Living with rare disease such as myositis is complex. You'll hear more about this from our keynote speaker later today, a dermatomyositis patient, Lindsay Gunsell, when she closes our program. A special thank you goes out to all of the care partners who help our patients navigate the daily demands of this disease. Speaking as a former myositis care partner myself, I see you and I thank you wholeheartedly. Next. Collaboration in research is vital to connect researchers and clinicians, ensuring progress in diagnosis, treatment, and care. We're grateful to the physicians and scientists and lab coordinators and research teams who do such an incredible job with this work. We want to express our appreciation to the dedicated professionals at NIH, FDA, HHS, and all the US federal agencies working to improve public health. TMA stands with you when we say rare diseases need more research, not less. In the myositis community, when it comes to the NIH, we are particularly grateful for the scientific advancements powered by NIEHS, as well as NIAMS. TMA was dismayed, but not defeated about the NIH FDA postponement of the Rare Disease Day program originally scheduled for today. However, we immediately sprung into action with wonderful peers such as Mira and Nori's fight. Like the members of our community who rise again and rise above, no matter what myositis is doing to their muscles, TMA, along with our collaborators in research and patient advocacy, are proudly offering today's We Care for Rare Summit, celebrating myositis science and patient stories on Rare Disease Day. Just a couple quick before we move on, a couple quick housekeeping items. There is a Q&A model in the Zoom, you'll notice. There'll be limited time for us to answer all questions, but please feel free to put those in there and we'll do our best to follow up to get all answers out to you. In addition, this is not an Ask the Expert program. This is an opportunity to share out myositis research. And also be cognizant, since it's webinar style, to make sure you mute yourself during the presentations. And we look forward to just an absolutely wonderful day. So I'll pass the mic over there to Paula as she takes our group photo.
Thanks, Laurie. And we are going to pull down the screen share and take a group photo with as many myositis zebras as are willing to turn on your camera. It's optional, of course, but if you'd like to join the group photo, please turn on your cameras and join us. And I'm maxing out the screen size, and I will have to click around and take a few shots, okay? So everybody hang in there, just keep smiling. 1, 2, 3. Okay. We're taking a group photo, so everybody keep smiling. It's a large group photo. It's quite a big family reunion. Wouldn't you say, Laurie?
Absolutely.
This is, in fact, the largest turnout for a virtual program that TMA has had in possibly ever. We'll have to get back to you on the exact numbers once we shift out of Rare Disease Day pop-up summit planning mode, but it's certainly an impressive turnout. Last
We're
group
like
picture, okay. We're gonna stitch this all together in the post-production and make one big collage. Go ahead, Laurie.
It's like we're a really big Brady bunch. It's the Mayo bunch.
I just love that a big group of zebras is called a dazzle. And I just really sense the myositis community dazzling today. Thanks for your patience with us on that group photo. And so thank you also to Laurie, our board chair, for that excellent welcome. And to kick off the scientific portion of the program, I'm very pleased to introduce TMA Medical Advisor and MIHRA Chair, Dr. Lesley Saketkoo. Lesley will be speaking to us about rare disease action and pride, along with Dr. Pedro Machado, MIHRA co-vice chair, and then we'll have reactions from Laurie as well as Dr. Namita Goyal, TMA Medical Advisory Board chair, and also from all of you. You know, as Laurie said, we encourage you to use the Q&A box and the chat, and we're looking forward to spending the next couple of hours together. So Lesley, again, with TMA's really deep gratitude for the MIHRA partnership that has made these super exciting myositis flash science talks possible. I will pass the mic and the screen share over to you. Dr. Saketkoo, take it away.
Hello, thank you. It's really wonderful to be here. We're so grateful, and wow, so many people showing up. And that's just proof that we are, when we need to, we stand together, and we're here to support each other and uplift each other. And my name is Lesley Saketkoo. I'm a rheumatologist with a special interest in cardiopulmonary diseases related to autoimmunity, and that includes myositis. I'm here with my co-chair, vice chair, of which Julie Peck is also another one, Dr. Pedro Machado. And so, Pedro, I yield to you.
Thank you, Lesley. And it is a huge pleasure to be here today. And I will start by introducing MIHRA. So MIHRA is a charitable non-profit research organization, and we try to bring together investigators from all disciplines, patient advocates, and partner organizations to support a vision. And that vision is to create a world where you can cure myositis together. We aim to achieve this by accelerating highly collaborative holistic research worldwide. And we serve as a platform where research organizations, patient advocacy groups, the pharmaceutical industry and regulatory agencies, they can converge to tackle complex challenges such as those that we've been witnessing in myositis, namely designing and implementing innovative clinical trials, strengthening professional education and training, building robust and sustainable research sites, and cultivating the next generation of myositis researchers and clinicians. Now, through these efforts, we are all working towards improving global care for individuals living with myositis diseases. We also offer some valuable online services, including a global directory of myositis specialty clinics. We also have an up-to-date listing of current myositis studies and clinical trials to help both patients and healthcare providers find relevant studies for their patients. And our goal is to invigorate professional education, enhance clinical trials, and fortify myositis research sites, all with the ultimate aim of advancing care and finding a cure for myositis. So next slide, please. There are approximately 7,000 rare diseases worldwide. In the United States, a disease is classified as rare if it affects fewer than 200,000 people, or about 1 in 1,650 individuals. Now, in the EU, a disease is considered rare if it affects fewer than 1 in 20,000 people. This means that in total, there are over 30 million people in the US living with a rare disease and over 36 million people in the European Union that are affected by a rare disease. This is approximately 1 in 10 Americans that will develop a rare disease in their lifetime. So rare is really not so rare. And importantly, rare diseases contribute significantly to chronic illness, to disability, and to premature death. And they affect both children and adults. In addition to the physical impact of the disease itself, living with a rare disease can severely affect psychological and social well-being. Unfortunately, many patients with rare diseases are often marginalized. Early detection and awareness is critical in managing these conditions and preventing the long-term damage and disability. In this context, myositis is an umbrella term for several rare diseases that affect the muscles and can also impact other organs or systems, including the skin, the lungs, the heart, and the gastrointestinal tract. Next slide, please. So living with a rare disease can often make individuals feel alone, outnumbered, or even less deserving of attention and care. However, an inspiring and surprising fact is that rare disease research contributes significantly to the greater public good. Many discoveries in rare disease research have often led to major breakthroughs in understanding and treating more common diseases. Rare diseases often provide valuable models and patterns that help clinicians improve their approach to diagnosing, understanding, and treating common diseases. So rare is more than just a number. So when we look at the approximately 7,000 rare diseases together, we see that rare is in fact a superpower, a powerful force for innovation, discovery, and improving care for all of us. Now, in the field of myositis diseases, countless researchers are working tirelessly toward finding cures, improving treatments, and developing strategies that allow patients to live more comfortably and enjoy life. However, research in this area does face several key challenges. The low incidence and prevalence of the disease makes large-scale studies difficult. The identification, recruitment, and retention of subjects is often challenging as the patient population is small and often geographically dispersed. Disease progression can be slow, making it harder to assess over time. Phenotypic changes can be difficult to measure and to track. Sometimes there's limited natural history data to guide research. Standards of care keep evolving or are not even fully established. And endpoint design and validation for regulatory trials can present a challenge. There's also a relatively lack of viable therapeutic candidates. However, things have changed significantly, I think, over the last few years, and organizations like TMA have had an important impact in these changes. There's an increase in the number of potential therapeutic targets developed through basic and mechanistic studies. Preclinical discovery and development tools are becoming more sophisticated with advancements in both in vitro and animal models, high throughput screening facilities, and more robust standardized operating procedures for therapy testing. I think diagnostic capacity is improving worldwide, aiding in better identification and stratification of patients. I think the infrastructure supporting proof of concept trials is also evolving. Genetic research is improving and uncovering disease-causing mutations in genetic rare disease, but also genetic modifiers that can be important in acquired diseases. So I think we are witnessing change and the emergence of new partnerships among advocacy groups, academics, corporations, governmental agencies, and patients are accelerating this progress. So, Lesley, maybe I'll hand it over to you now.
Hey, thank you. That was wonderful, Pedro Machado. So in rare diseases, we stand strong, and we have to stand strong, just like we're gathering here today. And we're really showing who we are, and we're here for each other. And courage is coming from Latin, courage in French. You know, it comes from the word heart, and it means big-heartedness. And we need this big-heartedness to face the challenges of living with a rare disease. And part of that is whether we're investigators or whether we're patients. In order to do a good job, we have to look after ourselves. We have to move our bodies for our health. We have to invest time to look after our nutrition and get good sleep and make good choices. Let's see. And connecting with, oh, I see, I'm a little bit off here. So, and we need to remember also that we may have a disease, we may be an investigator, but we are people first before we are a health condition. And we ask that of each other and recognize that we are people first. Too many things open on my side. And so in order to stay strong, connecting with others is crucial, like we're doing today. We're coming here together, we're standing with each other. But part of that is selecting those who bring us joy. That's part of self-care. Gaining disease knowledge. And it's very important that when we're gaining disease knowledge, we're doing that together as investigators, as patients, and sharing that knowledge. And if we are a patient, if we are an investigator or a clinician, understanding the strategies and skills related to self-advocacy in and out of the treatment room, those are things that can bring us closer to health and bring us closer to each other. One of the things that I've found in my life is that the more that I participate, the more that I learn, the more that I'm engaged with others. And I begin to feel stronger because I'm supported by this wonderful network of colleagues, both investigators and patient colleagues. And I think, yes. So, and in terms of research, we shine our magic. We shine our magic through our hearts, and relating to each other's hearts as human beings, and bringing to this difficult situation ingenuity, creativity, listening spirit, so that we can problem solve together through this current of sensibility to each other and to the question at heart. And we learn together. And we are out there raising awareness about myositis and rare diseases in general. And this is our magic. And we share with each other 360 perspective of what it is to be working within a rare disease as an investigator, and to be living with a rare disease as a human being. And it's only with these insights that we can help each other along. We don't know about natural history unless we truly know about natural history, unless we ask patients what from their lens, this blow by blow experience of what it is to live and live with the symptoms, how the symptoms evolved, to really understand the pace of the disease and the pace of the symptoms, and to really truly understand the burden, which also helps us to prioritize our research. And part of our magic is really remembering that the heart of everything that we do is not just brains, but it's brains about being bringing humanity to everything that we do, and not just saving the world, but saving our one-on-one relationships, and remembering that without everything else, if we don't stand together and we don't work hard to preserve our relationships, we lose our greatest asset. But we just will remember that we are all humans, and we are all navigating through this life as human beings. And so we all come with our triggers and our misconceptions. And but we learn, and we forgive each other, and we're always expressing gratitude to make it work. And when we step off and out of line, because we're humans, we are with gratitude, and we apologize, and we move on. And very important in our worlds of nonprofit work and science is that we recognize that not everything is truly urgent. Some things are urgent, yes, but not even those very urgent things in the scope of what we do, like getting a grant in on time. It's not the end of the world. And knowing those things that are of lesser urgency, so we can invite collegial compassion and compassion for ourselves, because that's the essence of being able to continue this work. And the other thing that we do and need to continue to do as terms of rare disease magic is to work to preserve our best resources. And what is that? First of all, that's patient time, and that's patient life years waiting for a cure. And that means avoiding delays in research through developing pathways that avoid delays and use funds efficiently, and do not keep patients hoping to get into a clinical trial in limbo while they're waiting to enter a rare disease trial. So that means expediting institutional delays, and having a special fast track for initiation of rare disease research. And as patients, and actually as investigators, we're sending out lots of qualitative surveys and expert perspective surveys. So the more that both of us, patients and investigators, can participate in all types of research, the further along we are going to get. and then ensuring that the community voice is driving the research, that the patient priorities are driving the research that's selected as priorities, and also that we as a community are guiding research as opposed to, well, dare I say it, the almighty dollar. Okay. So two quick examples that I'd like to share with you. And I'm just going to send out a couple of PDFs now and also a link to our patient contact registry. Hopefully everybody will get those now. But one of our posters that we were going to present at the NIH FDA Rare Disease Conference was our work with the carbon hand study. And what was marvelous about this study is that it took a year from design to implementation to analysis in this rare disease. And we were able to have sufficient recruitment for very good power. The carbon hand is a glove that is worn on the hand in people with neurologic deficits of hand function. And this is very important consideration in people with myositis, but especially in IBM, where it is a hallmark of the disease that hand impairment is progressive. And what this glove does is it senses the through the neurologic tone what the wearer would like to do. And what it does is it provides supportive force so that that task could be completed, whether it's grabbing or pincing. So what we did is we joined forces. This is how we got this study that would have probably taken 5 years to do in 1 year. Joined forces, we convened an investigator global team of physical therapists, occupational therapists, patients, of course, MDs. We designed the program. We circumvented institutional delays. And how did we do that? Well, we used a single site IRB as the NIH supports. And within 2 weeks, rather than the customary 8 months, we were ready to go in terms of all of our approvals, ethical approvals. We worked with industry, and industry was on board supporting us with training and providing us devices. And we then collaborated with our gorgeous patient organizations. So with the help of the TMA, Rachel Bromley, Linda Colbert, we were able to get this trial fully recruited over the weekend of the TMA conference. And this was a positive trial that demonstrated a clear benefit for patients with IBM in feasibility and usability. The other study that demonstrates that we were going to share at the conference that demonstrates the community voice coming together and rare disease magic was the CAR T studies. And everybody has heard about CAR T studies by now, I'm sure. It's very exciting. It's a very aggressive form of treatment, but it's a very important resort. We were finding that as a patient community, as an investigator community, that we were feeling a little bit inundated by the number of these types of trials. They were outnumbering our other types of myositis trials. Patients were feeling a bit pressured with ads and not feeling they were getting enough information, and the same with the investigators, not sure what we're getting into. So under qualitative research expertise, we decided to go to the community, ask the community, get guidance from the community, find out what's going on. We did so through eliciting open narrative on surveys, analyzing this data, holding a live forum, presenting what we learned, drilling deeper into these potential issues. And what we found was patients and investigators shared many of the same concerns, like I mentioned, too fast, many patients being recruited at once without really understanding the safety implications, need better information, materials. That was very clear. And we were also concerned that patients that might be enrolled may have actually benefited from trying safer, effective options. And how do we control for that? And also, ultimately, there was no agreed upon treatment algorithm to define what exactly treatment failure was, which actually will impact patients from getting the appropriate care and this being used as a last resort, but also impacts the data coming in, that we're really defining, having well-defined inclusion criteria. So again, the end of this provided several deliverables that we are working on currently, which includes patient-centered, patient-driven communication protocols and educational materials, developing treatment algorithms to define what is truly treatment failure, engaging in dialogues between regulatory agencies and industry, patient, investigator communities, and also supporting our investigators so their time is not wrapped up in the logistics of setting these complex trials up, but rather caring for our patients.
Thank you, Lesley, so much.
Yes.
This is Paula, TMA's executive director, and that was a terrific overview. And I think you and Dr. Machado shared so much about what we can take pride in for rare disease. And I think it's not widely known that many of the advancements that have benefited all of human health have originated in rare disease. So this was really fascinating. I would like to invite Dr. Goyal to briefly react and to reflect on the question we've received about how the NIH sort of pauses and disruptions may impact myositis research now and going forward. So let's pass the mic to Dr. Goyal and then back to you, Lesley.
Well, thank you, Dr. Machado and Dr. Saketkoo. I couldn't agree with you more about your comments and your thoughts. For those of you who don't know me, my name's Namita Goyal. I'm a neurologist, I'm a myositis specialist, and I've had the amazing honor of being chair of the Medical Advisory Board at TMA. I've actually been a part of the TMA community for the past 10 years. And I'm so grateful to be here today. I'm a physician scientist and I work daily to try to improve the lives of patients with myositis. It's really because of this increased awareness that's really led to a surge in research and therapeutic developments. And this has happened, like Dr. Machado and Dr. Saketkoo has said, because of efforts of collaboration from a network of clinicians, scientists, pharmaceutical companies, the NIH, but most importantly, from all of you, the patient community. I'm really honored to be a part of this community that works so tirelessly and fiercely to improve the lives of patients with myositis. So to answer Paula's question, I look at this NIH interruption as a pause, but I have seen from even just this program today that it is not stopping any of us on the myositis side. The researchers, the scientists, the clinicians, we are still continuing our work. We don't anticipate stopping any of our work. Our passion remains, and irrespective of what the NIH is planning on doing, which none of us know, we are continuing our work. And thus far, the message has been to continue our work. And so I don't really foresee it being a major hurdle or barrier for our care in myositis. And I think this program really attests to the devotion and commitment that us myositis experts, community all have. I think this meeting is going to be a wonderful testament to the commitment that we all have in myositis research.
Thank you so much, Namita. Dr. Machado, would you like to make any additional comments or reactions?
Well, being a person living in the UK, I see the news in the US with great concern, let's say, but I also have a lot of confidence, trust in my colleagues in the US and various organizations that um, I'll know will be able to overcome the difficulties and they will be resilient and the rare disease research will win. And we on the other side of the pond, we're supporting you all, and we can count on us, to partner with you in the even if the times to come might be difficult.
Thank you so much, Pedro. That's so well said, especially the part, if you don't mind that I repeat you, where you said rare disease research will win. I feel that very deeply, and I know all of you do too, and I really feel the support as well. And thank you so much on behalf of our community. While we would have very much enjoyed the privilege of interacting with our medical advisors and these esteemed scientists at their posters at the Rare Disease Day program at NIH and FDA that was postponed, this is truly the next best thing. So, Lesley, back over to you to lead us through several flash science talks. And this is going to be a little bit fast and furious, as the saying goes. So, consider this a sampler of science, if you will. Lesley, flashing back to you.
Can you see the slides okay? Yep.
We can,
Yes.
yeah.
Okay, wonderful. Well, welcome to this exciting journey that we're about to be on together. And we're going to begin with a patient-driven discoveries and priorities, preferences, and attract to research from the MIHRA heavy lifters, Ingrid de Groot, Leah Kolsters, Marie-Christine Breveld, Karen Norris, Karen Chung, Helian Alexanderson will be popping in for the MIHRA heavy lifters. And the question is, does over-reliance on manual muscle testing in myositis commonly negate patient voice? And does this cause treatment delays leading to long-term disability? This is the question.
Thank you, Lesley. Hello, everyone. My name is Ingrid de Groot. I live in the Netherlands and I'm a medical advisory board member of TMA. And I will talk you through this fascinating short presentation. The heavy lifters, as you see here, is a small group of women living with different types of myositis, who have been sharing experiences regarding diagnosis and treatment. And we found out that we have a lot in common, in the sense that we all used to be very active or even athletic women who know their bodies very well, and who, as a consequence, knew for sure that something was wrong long before any doctor could or would confirm this. So idiopathic myopathies, as we have heard, are rare diseases of muscle injury, which can also affect lung and skin, heart, and the GI system. And the muscle severity varies, and a widely used and heavily relied upon instrument by clinicians to measure this is the MMT-8, where the MMT stands for manual muscle testing, and Helene will talk us through it later. But however, active disease or flares can be undetectable by using the MMT-8, because what we found out by talking was that as athletic patients, we all performed well or above average for women our age in this MMT-8 test. And we also learned that this was often the reason for withholding or postponing treatment at the time, despite the fact that some of us reported progressive muscle weakness or even provided doctors with objective records of deteriorating performance. Also, concurrently, active skin disease did sometimes not lead to muscle treatment. As such, over-reliance on MMT-8, leading to possible treatment delay and potentially to long-term disability as a result of that, is a key concern for people living with myositis. So we will now give short introduction. This is me. I was diagnosed with dermatomyositis in 2007, and the first signs that something was wrong were skin symptoms on the eyelids and on the hands and the fingers, plus the fact that I could not keep up any longer with the men in my sports group, and those were men I had been working out with for years. And despite increasing muscle weakness in shoulder and pelvic area, this decreasing muscle endurance and prolonged recovery time, my high score on this MMT-8 test was one of the main reasons to delay muscle treatment, which started only 2 years later. And by that time, also my neck muscles and breathing muscles were affected. And despite this treatment, I never regained my former performer levels. Next, please. Karen?
Karen?
Hi. I don't see my slide, but hi, I'm Karen Norris. Can you hear me?
Yes.
Yep.
Okay. Hi, I'm Karen Norris, and I am a 3-time Paralympic swimmer. I have 3 world records and 7 medals to my name. And in retirement, I still trained seriously. A few years ago, I experienced a 15% drop in my performance in just a matter of 2 months, which was extremely alarming and unexpected. So the next 2 years, I spent visiting countless doctors, and I'd show them my rash and my itch, and I'd talk about my cough and countless other symptoms in addition to my performance drop. They'd do the manual muscle test and they'd say, "Oh, you're strong." And I'd say, "But you don't know how strong I was a little while ago." But they would dismiss that and they'd say, "Maybe you're just depressed." And so it took 2 years to get diagnosed and start treatment. It was extremely frustrating, and well, let's change that. Next.
Thank you, Karen. Leah?
Slide, please.
I think the slides are just a little bit delayed, but it's up on my side.
Thank you, Lesley. Hi, I'm Leah Golsos. I'm 13 years ago, I was diagnosed RA, and after 2 years and 44 pounds less, I got the anti-synthetase syndrome. For my profession, I was working in construction, being a tile layer, and often I lifted 38,000 pounds a day. So that's about 2,550 stone. After taking immune suppression for long enough for it to work, tapering down became the main fight. Though creatine kinase wasn't high enough to take immediate action, I became weaker. The MMT-8 test became the standard check. Though this said nothing about the strength to perform and only that moment for one attempt. So in their opinion, I was scoring above average for a female my age. So this left me taking prednisolone for 6 years before I gained remission eventually with Rituxan. 6 years of muscle loss and gaining loads of myositis related diagnoses like GERD, oesophagus paralysis, costochondritis, and several more. Could this all have been prevented? Maybe not all, but at least a few, or at least half of my lost muscles. Next.
Thank you, Leah. Karen?
Hi, everyone. I'm Karen Ching. I was originally diagnosed with polymyositis in Singapore in 2006, and I now live in Switzerland. And last year, about 20 years later, we found the SRP antibody, and I'm officially classified as IMNM, immune-mediated necrotizing myopathy. I do believe that my early diagnostic and treatment path, because I was stereotyped as a very young patient and a very active patient, that perhaps the more aggressive treatments were not offered to me early enough, which resulted in me spending about 1.5 years in a wheelchair. And it wasn't until I couldn't swallow anymore before I got IVIG. I do think as well that a heavy reliance by the clinicians on just clinician-reported outcomes may not always concur with what the patient is feeling. And in terms of our fatigue and endurance issues as patients living with myositis, this often does not show up so well on the MMT-8 score. Next.
Hello, everyone. My name is Marie-Christine Breveld. I was trained as an occupational therapist and later became a manager of health centers. I'm a sporty lady. In the top right photo, you can see me sailing at the World Championships in the Bahamas. When I started to lose strength, I still sailed races and was very muscular. I did my own research and was afraid to have IBM. In the past, I treated patients with ALS, but this syndrome was different. My neurologist saw a muscular woman and did not believe me. My request for a muscle biopsy was not honored. In the manual muscle test, I was very much stronger than her. She asked me to do a deep squat. She did not accept that I indicated I could not do a deep squat and forced me to do it anyway. I fell flat on my back. Finally, I was diagnosed with ALS in late 2018. Even in the second opinion, I was diagnosed with ALS. A year later, after a muscle biopsy, I was given the correct diagnosis of IBM. To all doctors, patients may hold some valuable information. Thank you.
So based on our common experiences, we discussed and arrived at 4 major strategic areas that we should be working on.
You're running low on soldiers.
We considered the existing evidence regarding patient-relevant measures. We discussed some actions to understand the patient experience in a wider context.
Karen, I'm sorry. Can everyone see the slides? I just got a text message that someone can't see the slides.
Yes,
I see the slides on my side.
Major.
I see them.
Okay, great. What number are you on, Karen?
If you can just show number 2 again. So we took some actions to understand wider patient experiences, and we have today, even in the PDF that Lesley has just shared in the chat, we are trying to provide already some immediate patient-relevant guidance for clinicians, and also we are considering how the patient community can support research efforts in this area. Next slide. From the light literature review that we've scoped, we've noticed that reliability issues do exist relating to the MMT-8 testing. There were also some literature regarding the FI3, the functional index 3, which Helene will talk a little bit more after this slide, which appeared to be more sensitive, had more granular measures, and were better in terms of objectivity than the MMT-8. Muscle impairment may not necessarily mean active disease. However, also active muscle disease may be suggested by a shorter disease duration, progressive impairment or gradually slow progressing disease, flares, and also active disease in other organs such as the skin and the lungs. There is currently no standard assessment yet for skin with myositis-related disease activity, and also there is no currently acceptable scale which exists for patient experiences of skin and muscle. Helene, over to you.
Hello, everyone. I'm very excited and glad to be on this meeting together with all of you on this important day. I'm a physical therapist specializing in myositis, living in Stockholm. So I'm going to discuss some performance differences between the manual muscle test and functional index 3. Next. So the manual muscle test 8 muscle groups, MMT, measures isometric muscle strength, the force that you can produce over 3 seconds. And it includes 8 muscle groups, and the score ranges from 0, which means almost no muscle activity, to 10, which is considered as a good muscle strength. Next. There is, however, some complexity of subjective bias and application of technique. So for the MMT grades, 6 to 10, where the patient is rather strong, so the assessor puts on extra resistance to try where that the patient is supposed to uphold. But here it is dependent on the stature and the strength of the assessor, not only the patient. Next. So the functional index 3 measures muscle endurance rather than isometric muscle function. And as we heard, the myositis heavy lifters, and as I hear in my clinic from many people with myositis, is that muscle endurance seems to be more relevant than the isometric muscle strength. The FI3 is also more sensitive to detect muscle impairment and muscle changes. It measures 3 muscle groups, and it is the patient performed independently. The assessor is only observing, counting number of repetitions that the patient can perform, and is not involved in putting on extra resistance or so. These are the 3 muscle groups: shoulder flexion, head lift, and hip flexion. And with this slide, I want to show you, I don't know, can you see my pointer? No.
Yes, we see it, Ellie.
Okay, so on this axis, we have the manual muscle test, 0 to 100%. And on this axis is the FI3, FI2, from 0 to 100%. And as you can see, the majority of cases, 1 dot is 1 patient, are performing very well on the MMT. There's not much room for improvement. This individual performs 100% on MMT, but on the same time cannot perform any of the repetitive measures in the functional index 2. So most patients here seem to struggle to cope with the endurance tests. So I think this means that it's not, the MMT8 is not sufficient to capture a muscle impairment in myositis. Thank you.
Thank
Thank you. Thank you, Ellen. Okay, so regarding the second major strategic area, we discussed possible ways to investigate wider patient experience. And we plan to do this through open-ended surveys to obtain experiences, and later on also surveys to quantify these experiences and stories, which we'll then share with the patient and investigator communities. And to provide immediate patient-relevant guidance for clinicians, our discoveries prompted us to compile 2 preliminary guides to integrate patient-reported experiences and to prevent treatment delay. First, a patient-relevant diagnostic guide with points to consider the likelihood of active disease. And secondly, a guide to navigate the shared decision-making process between patients and clinicians. And Karen will now take you quickly through these 2 guides.
Thanks, Ingrid. So these are some points of guidance for clinicians to be alerted to active disease, even when measures such as the MMT8 scores reflect otherwise. We hope that this will help to avoid any treatment delay, which could result in muscle damage and long-term progression of myositis. Many of these are interplays of symptoms versus signs and may affect some of the treatment selection that the patient receives. While we don't have time to go through each of these, there will be a PDF available. I think Lesley has already shared that. as well as we will share further information on the MIHRA website.
The PDF is in the chat as
We also identified some critical areas for two-way conversation between patients, the care partners, as well as the physicians, on whether these treatment decisions can be made when active disease status is unclear. Although these discussions do take time in the clinic, it can make a big difference in the patient outcomes. Again, we will not go through each and every one of these points, but please refer to the PDF. And MIHRA's website will also have this information, or just feel free to reach out to any of us after this meeting.
Thank you, Karen. So when looking at the fourth major strategic area, which is how the patient community can support all these efforts, we aim to increase patient involvement in improving clinical assessment in myositis. And this could be done by several ways. One is by involving patients in all phases of a study, from study design to implementation and dissemination. And patients and their advocacy organizations can help by participating in focus groups, in surveys, or by providing feedback to researchers and investigators, for instance, in the development of apps or measurement instruments. And finally, and importantly, patients can help by joining the MIHRA Patient Contact Registry, which you can do through the QR code you see here on the right, or through the link on the MIHRA website. I thank you all for being here today, tonight with us. And on behalf of all people living with myositis and their loved ones, I want to express my sincere gratitude to MIHRA for their decided commitment, their dedicated commitment to holistic science, and for the acknowledgement of the patient voice herein. Thank you very much.
Thank you, everyone from the heavy lifters. That was really super and amazing. I'm so grateful for this time, your voice and your work on this. Is Vicky Worth in the audience? And is she here? Ready?
Yes, I am here.
How fantastico, Vicky.
Okay.
Okay.
Okay, so I'm going to be talking. Can you hear me pretty well?
We
Oh,
can.
yeah.
Okay.
And you have just about 5 minutes, Dr. Worth. Thank you for your
Okay.
brevity and your expertise. We love our medical advisors. Thank you.
Thank you. Okay, so we're going to talk about unintended consequences of clinical trials in rare diseases. I think we've already heard about some of the issues around muscle exam, and I'm going to be focusing more on the skin exam. So next slide. And I do some work to try to advance studies. And so this is just letting you know some of the work that I've done. Next slide. And so we already know about myositis, so I can really be very brief about that. But we've talked about the TIS as more of a muscle measure, which includes the MMT8. And so the TIS is being used as a primary outcome for most studies. What that means is there's no direct measure of skin activity, and we'll talk about the implications of that. Next slide. So it basically, because the TIS is more of a muscle measure than anything, it means that the trials are mainly recruiting patients who have muscle disease. And we know there are many, many patients who have only skin disease. And what that means is that the trials are being done with skin patients not included. And when drugs get approved that help the skin, it's pretty hard to get it for the patients who don't have muscle disease. And so that's sort of the capsule summary of what I'm going to tell you. But there's a lack of skin assessment, and we can go to the next slide. And basically what we know is from a patient voice that the skin is really important to people. So what this was actually was a survey or poll that was done during a patient-focused drug development that was involved TMA and as well. And what you can see here is that the skin complaints were like the highest number of complaints that patients had. And below that was fatigue, and even below that was muscle weakness. So you can see a problem of only having a muscle-focused measure is you're leaving out a big complaint that people seem to have. Next slide. And so we do actually have a skin measure that's been validated and used in many of the trials as a secondary outcome. But because it's only secondary, it means that we can't, when the approvals happen for the muscle patients, it doesn't necessarily extend to the skin. Yeah, keep going. So the CDASI, can you go back? CDASI in combination with measures of muscle weakness and overall DM disease activity may better capture improvement. And so we've developed a new measure, next slide, that allows us to combine elements of the TIS, namely the MMT that you can see up there, and maybe someday we'll be swapping out the MMT for the FI3 that we were just hearing about. And then the CDASI you can see is the skin measure, and they're given equal measure here. What we're showing you with the improvement scores, identical weight to muscle and skin. And then there are global assessments from the physician side and the patient side. And all of these together can give us a composite tool that will allow measuring our patients. Next slide. And so we applied that to a study that we did, a phase 3 trial. And what this is showing you is that when you use the TIS, which includes the MMT, that when the patient wasn't better on the skin response side, the left side, they weren't better with DMOMs. But when you could show that the patients were better in terms of the skin with TIS, they were even better with DMOMs, and that's not surprising because there is a direct measure of skin. So the orange line is doing better than the blue line, but we can, in this kind of situation, include patients who are skin-only patients with significant dermatomyositis, with itching, and really a problem. On the right-hand side are the muscle responders. And what you're seeing here are the people who didn't respond to this particular med. The TIS and the DMOMs didn't show very much. It's a flat line at the bottom there. But when you look at the muscle responders, again, you can see that the DMOMs captured the muscle responders better than TIS. And that's, again, I think, a reflection of the fact that often the skin and muscle get better together. But again, more sensitive measure. Next slide. So compared to the TIS, DMOMs is simpler. It's 4 instead of 6 components. It captures greater improvement in both muscle and skin, and it seems to perform well as an outcome measure in dermato trials that include patients with both muscle and skin activity. Next slide. So what is the impact of, again, not having a skin involvement? Well, 20% of dermato patients have no detectable muscle involvement, and they're not in trials. 40% of classic DM patients with muscle disease, and we've heard a lot about the muscle disease, but in a lot of patients, it does get better. And then you're left sometimes with chronic sort of skin issues. And those patients also, because they're not weak, cannot be included in trials. So we're excluding a lot of patients. And we know that the skin is important to our patients. Next slide. So failure to include these patients means that it can be hard to access. And I'll give you an example. So we use IVIG for dermatomyositis, whether it involves muscle, skin, or both. So we've been using it for many, many years, and we were lucky to get really a very unique approval from the FDA for use of IVIG in a trial, which was great that the trial was done, but the only patients in the trial were muscle patients. They had to be weak to get into the trial. What that meant is when we got that approval, some of the skin patients started having trouble getting IVIG. And I now spend time doing peer-to-peer complaints with the insurance industry to try to get IVIG approved. So it's really important to include our skin patients. And so keep going. Next slide. Yeah. Accurate, go back. Okay, so we want to have the ability to include all our patients. And if we can do that, it will prevent loss of access to meds for patients whose active disease manifestations fall outside of trial inclusion criteria. Including more patients in trials of novel therapeutics will be very helpful because there are such limited treatment options, and we all really hate the use of steroids. Protecting recruitment is really important because we won't be having studies if we can't fill the studies that we have that are very exciting with really great drugs. So we need to be able to broaden out who can be in trials for a rare disease. And I think that that's the bottom line is we are really all of us together working to validate DMOMs in more of a clinical trial setting so that we will be able to enroll many different types of patients. Thank you very much. And this is to acknowledge all the people that have contributed.
Dr. Worth, thank you so much. I would like to say Dr. Worth and all of the speakers there here are most of us are TMA medical advisory board members, and everybody that is speaking is a lead within the MIHRA or foundation, including our next speaker, who is Dr. Helene Alexanderson.
Thank you, Dr. Saketkoo. I'm going to speak a little bit about why exercise is a vital part, excuse me, in the treatment of myositis. And as we have been talking earlier about, it's important to distinguish between active inflammation and damage. So in remission, when there is no active inflammation anymore, exercise is actually the only effective treatment to improve physical health as well as psychological well-being. Next. And with this slide, I want to show how the view on exercise in myositis have changed dramatically over the last 30 years. In the 1990s, when I started to study myositis, all textbooks said it's harmful, you shouldn't exercise, you should rest, especially if you have a recent onset or disease or flaring. But since then, more than 40 publications support safety and efficacy of exercise in people with myositis. And today we're actually back. And today we're actually investigating safety and effects of high-intensity interval training in recent onset myositis. So exercise is a cornerstone in the treatment of myositis. Next. So physical activity is any everyday activity producing increasing energy expenditure above resting sitting levels. And next slide will show health enhancing physical activity recommendations. Exercise is a planned physical activity is a planned physical activity with a goal to improve physical fitness. And we can establish an exercise dose by using the fit factors: frequency, intensity, time. And that means the number of weeks or months that you have to continue to start to see an effect, and what type of training we are doing. Now, Lesley. Thank you. So these are recommendations from the World Health Organization, which is based on very strong recommendations from literature. And we should all strive to achieve these recommendations for physical activity. And we know that people with myositis often have, from the beginning, an increased risk of cardiovascular disease, type 2 diabetes, cancer, fatigue and pain, and so on. But striving towards these recommendations can give you a lot of very important health benefits that you can see listed on the left. So we should try to be physically active at least 150 minutes on a moderate level. And that means you get your heart rate up, but you are still able to talk. Or do at least 75 minutes of very vigorous intensity activity, which means that you have a very high heart rate, you're not able to talk to anyone. And in combination with this, we need to do strength training twice a week. It's important to minimize the sedentary time. So just standing up from the computer, getting a cup of coffee before you sit down again, that actually has health benefits. And for people with myositis, and as well as for people over 65, it's important to train your balance to reduce the risk of falling. And this might seem as very challenging to reach these goals. I think we all might be struggling, but you can start where you are, and if you just increase a little bit, that will give you health benefits. And it can be a long-term plan on how to be more physically active. Next. This is a home exercise program that has been extensively back. No. Oh, sorry. Okay. There are studies showing reduced depression and disease activity. So this study looked at 24 weeks of functional strength training in non-IBM myositis. And as you can see to the left, the black line is the exercise group, and they had significantly reduced depression compared to the non-exercising control group. And they also had markedly reduced disease activity in the exercise group compared to the control group. Next. This is a home exercise program that we have developed. So you do these exercises 5 days a week and can combine them with a 20-minute walk. And this program has been extensively evaluated as to safety for people with recent onset active or flaring myositis. And it can improve muscle endurance and quality of life. And importantly, we could see some reduction in bodily pain. And when comparing this program to a randomized, to a non-exercising control group, it showed that those who started training already at time of diagnosis, they had a much higher level of physical activity after 1 and 2 years. And they were also improved in muscle endurance and aerobic capacity in the long-term follow-up compared to the non-exercising control group. Next. This is a program that you can do when your disease is less active, when you don't have so much inflammation. It's training twice a week, mainly biking. You can start on a lower level, but slowly work yourself up to the goal intensity. And next. And here we could see an significant and clinically relevant improvement in aerobic capacity in the exercise group compared to the control group that were a little bit worse after 12 weeks. We also looked at lactate levels. Can you go back? So lactate is a byproduct of energy production when your muscles work hard with little oxygen, and it can make your muscle feel fatigued. So we could see a significant reduction of lactate levels and a more than doubled biking time to exertion compared to before training, and also compared to the control group where you couldn't see any difference. Next. This program also reduced disease activity and fatigue. It increased the number of small blood vessels in the muscle. Genes related to muscle growth and blood vessel growth was upregulated. And this together show that exercise not only improve whole body aerobic capacity, but also muscle aerobic capacity. And genes related to inflammation were downregulated. Next. This is a home exercise program that was developed and evaluated specifically for people with IBM. And it's a 16-week program where the goal frequency is to do it twice a day for 16 weeks. You can start on moderate intensity only once a day and slowly move up to goal frequency. It's important to have frequent telephone follow-up and measure function and strength in between to make sure that this training program is well tolerated. It showed that muscle strength improved also in muscles that are most affected, such as the quadriceps, the thigh muscles, and finger flexors. Patients improved in their ability to stand and walk. And here are some slides that show results from our recent exercise study that we did at Karolinska University Hospital. And we looked at safety and effects of high-intensity interval training in myositis. Next. So the HIT program comprised of 3 sessions per week. The goal intensity was to do 6 30 seconds all-out intervals where you reached at least 85% of the maximal heart rate. And then you have 2 minutes with active rest in between. And then they did strength training. And the control group performed the home exercise program that we have been using. I showed it a couple of earlier slides that we have been using for many years. And next. We could see that this is the exercise group, and they improved 16% in aerobic capacity. So the dotted lines is 1 patient, and this is the mean value. And 16% is a very large improvement. A 10% improvement is clinically relevant, and that was this statistically significant improvement compared to the control group, who only had a 2% change. We could also see that the HIT improved in muscle endurance and self-reported physical function and general health compared to the home exercise program. In both groups, there were some signs of reduced disease activity. In the HIT, reduced the pulmonary disease activity. And there were responders according to the new total improvement score. Overall, there were otherwise no changes in CK levels or pain or fatigue. Next. So in summary, exercise have positive effect on physical capacity, disease activity and inflammation, muscle health, fatigue, and psychological well-being. Exercise should be individually adapted to physical fitness, pain, and fatigue. And this just hit the button many times. These are all the organ systems, or many of the organ systems in your body that are positively affected of exercise. So exercise is medicine. Thank you.
Kellyanne, thank you very much. Now this was a beautiful talk. We are now moving on, please, to Dr. Ellie Naddaff, also a TMA Medical Advisory Board member and also a leader in MIHRA. Ellie, are you here?
Yeah.
Beautiful.
Thank you, Dr. Saketkoo. So in these 5 minutes, I am just going to touch base on how our strength lies in unity from a different perspective. Because the disadvantage of just saying that if we put our numbers together, we're not that rare, it's still buying into the concept that numbers matter. While in fact, every patient deserves to have the most accurate diagnosis, the best outcomes, best treatment regimen, which is the foundation of precision medicine or individualized medicine. And the best part of research to help further illustrate that concept is translational research or translational sciences, which I will share some examples with you in these 5 minutes. Next, please. So to demonstrate that, we would have to consider novel concepts. One of which is there's a difference how we approach a research topic if our aim is diagnosis versus therapeutic approach. Because if we want to diagnose someone with a disease, we want to highlight the most specific findings that occur only in this disease, the most specific biopsy finding for that particular patient or disease. However, from treatment perspective, it doesn't work like that. Different diseases can share different mechanisms, and findings or breakthrough treatments in one disease could be borrowed to other disciplines and other domains and other diseases. Hence, the rarity really does not matter. And that's what translational science is, bringing basic science or benchwork closer to clinical application, and also application of these findings across multiple disciplines, and hence strength is unity regardless of the numbers. The other concept is how we're approaching these diseases that I will illustrate in a research project that was published. Next, please. So there is no better way to illustrate that concept than IBM and the relationship between IBM, aging, and mitochondria. As now mitochondria and mitochondria therapeutics is a hot topic in aging, and all aging-related diseases share a lot of common mechanisms that we're hoping any breakthrough treatment in one area could be borrowed and translated to other diseases if we can find that same pathway, same mechanism also happens in that disease. Next, please. And IBM, although classified under idiopathic inflammatory myopathy, it is a disease of aging by definition, and it affects males more commonly than females. It does not respond to immunotherapy. And almost every single IBM biopsy patient has evidence for mitochondrial dysfunction, and mitochondria are the mothers of aging. Same with the other form of myositis. There are also shared pathways through the mitochondria. Next, please. And what made that field very interesting, because the old concept of the mitochondria are the powerhouse of the cell is very outdated. The mitochondria role is not just to produce energy. And it's not just a black or white, is there mitochondrial dysfunction or not? The mitochondria are very rich and complicated organelles. Yes, they produce energy, but they regulate metabolism, they regulate our immune system response, and also they decide the cell fate and when the cell has to die to just limit the damage. Because of that, they are now considered a signaling organelle. And every disease will have mitochondrial involvement. But the question is what type, what mitochondrial behaviors and functions are affected in each disease. And any treatment for any of these behavior, any of these functions could be translated across disciplines. Next, please. So to give you an example, this first project was already published where we focused on one of the mitochondrial function, which is called mitophagy and the inflammasome activation. Why it makes sense? Because IBM, one of the most prominent features of IBM is inflammation and mitochondrial abnormality. And we know that the mitochondria play a major role in regulating inflammation. And this is the link to the paper that's already published. But to summarize it in just 1 minute, under normal condition, when our body is subjected to any form of stress, whether it's relating to aging, to the environment, or others, the mitochondria leak some of their content, and that content is known to trigger inflammation. Specifically, one type of inflammation that you'll be hearing about is called the inflammasomes. The inflammasomes are now implicated in many diseases of aging, Alzheimer, Parkinson, loss of muscle with age, sarcopenia, and aging itself. Hence, the finding in one disease, regardless of its rarity, could have major impacts on other fields as well. But under normal condition, in individuals with intact mitophagy is the ability of the cell to eliminate damaged mitochondria and take them out of the cells. Then the cell will get rid of these damaged mitochondria, will get rid of the inflammasome, and the cell normal function is restored. In IBM, we have mitochondrial damage, leakage of mitochondrial content, triggers inflammation. But now the cell cannot get rid of these mitochondria because the mitophagy is impaired. Then we have more oxidative stress, more mitochondrial dysfunction, more inflammasome activation, and so on and so forth. This creates what's called a vicious cycle, or a vicious cycle that's self-sustained and causes a lot of cell damage. And that's a new concept of all the diseases of aging. We probably may not find what caused the disease. It's not just a cause or effect. But from day one in those diseases, there are some vicious cycles that are happening, and we need to know how to break them, how to intervene on them, regardless which came first, the mitochondrial dysfunction or the inflammation. It does not matter because this cycle is really damaging the cell. Most importantly, there are very major sex differences, and males with IBM have way worse mitophagy, probably, than females. That could also explain some features of the disease. Next. And in the slide, I'm just summarizing the second project. It's published, it's posted on bioRxiv and currently under review. where we defined the metabolomic map in muscle of patients with IBM centered on the mitochondria. And we show different metabolomic shifts that are shared with other diseases of aging, with diseases of muscles, with sarcopenia, and so on and so forth. And the only part of this project that I'm showing you here is when you correlate these changing in metabolism, changing in genes with clinical findings, you see what correlates with what to just have some idea of what's clinically important. And then when you look at that table here, the strongest correlation of these changes is with sex. That tells us there are a lot of genes and metabolites that drive disease differently between males and females. And also a lot of these correlate with the loss of strength, meaning they are of clinical significance. We don't know yet what's causing the disease, what's a reaction to disease. We're just still describing what's going on. And with that, we would open up all these findings that are shared with other diseases. For instance, there are now treatments for mitophagy in Parkinson's disease already in clinical trial. If we further demonstrate what type of mitophagy defect are happening in IBM, could we borrow that treatment and try it in IBM? And that's the beauty of translational sciences and the importance of funding translational research. Next, please. So for the most part, translational research is funded by the NIH. And of course, foundation play a role in that as well. Not much with the pharmaceutical company. And therefore, the current changes with the NIH and the uncertainty of the NIH could markedly impact translational research and could even bring it to a stop, also knowing the US is a leader worldwide in translational research. If we want new treatments, new targets, new diagnostic biomarker, that all happens under translational sciences. I personally had minimal impact on me, nothing compared to other people, but as a follow-up study to this, I had submitted an R01 application that was supposed to be reviewed 2 days ago, but unfortunately that meeting is now canceled without any instructions on if that will happen and when will it happen. Hopefully that's short-lived. And again, this translational research, translational science is another example how our strength is in our unity and how numbers do not matter in the field of research and improving the quality of life of patients with myositis. Thank you.
Thank you, Ellie, Dr. Nadav. So grateful for that wonderful talk. And now we are going to talk, because we're mitochondriacs at MIHRA, we are going to talk about now more mitochondria with our very esteemed colleague, Dr. Christian Lud, who is also a lead for the MIHRA Biodata Core. Thank you, Christian.
Thank you, Lesley. Yeah, I'll continue on the same topic as previous speaker here and discuss how our power plants, the mitochondria, may be on the go in myositis. Next one, please. So as noted in prior talk, mitochondria, we usually think about them as these power sources, and they're inside of cells producing a lot of energy, which is important for our cells, not least our muscle cells. But however, it's worthwhile noting that we don't think that mitochondria are human. We think they come from bacteria originally. They coexist with us. And as such, they also contain many things that look like bacteria. And since they look like bacteria, our immune system is very intrigued by these mitochondria. However, the crux here is that unless we think about the inflammasome that Dr. Nadav mentioned, our immune system will not see mitochondria if they are still within cells. But if they are seen by the immune system, they can evoke autoimmunity. We see a lot of autoantibodies towards mitochondria in different myopathies. And we know that these mitochondria can promote inflammation. But would it be that a mitochondria would be seen outside of a cell? Are they on the go, or do they stay inside of cells? Next, please, Lesley. So we have reason to believe, both in myopathies and also in other inflammatory diseases, that mitochondria do not stay within cells, but they actually move. They move around. And we can see this in inclusion body myositis, where we see in the fibers that they are COX negative, meaning they lack mitochondria. where are the mitochondria going? We see in JDM in the lower left page, or using electron microscopy, that muscle tissue are pumping out, throwing out mitochondria into the extracellular tissue, depositing them for our immune system to see them. And we have published a paper describing on why and how that is happening. But also in our peripheral blood, our immune cells, like neutrophils or platelets, they can also, when activated, release these power plants that are now inflammatory, looking like a bacteria in your blood. And one of those important molecules that they release, we refer to as FMET here in red circles. So this is, of course, all theoretical. Do we then have evidence that this is occurring in patients, and what are the implications of that happening? So next slide. So we have measured these mitochondrial peptides in the blood from a ton of different patients and different disorders, and we do find in both juvenile dermatomyositis, adult dermatomyositis, and inclusion body myositis that patients have elevated levels of these mitochondrial markers in blood. So it's something we can measure in the lab. And this seemed to reflect very well muscle function. Though we may not agree that MMT8 is a good marker or not, this is a soluble marker you can measure in blood that even in IBM seems to correspond to muscle function. And this would be one of the first, if not only, good soluble marker that we have for IBM to study disease activity or muscle function. So thinking now about us having all of these mitochondrial markers, mitochondrial components, if you would, in blood, the question is, do these contribute now to peripheral systemic inflammation in these patients? So next slide, please. So this is going to be a little bit messy, but I'll try to lead you through it just to give you an overview of what we're trying to accomplish with this project. We do try to bring novel biomarkers to the market to try to help investigators and clinicians to monitor better disease activity and so forth. But when it comes to long term, we try to identify new mechanisms of how inflammation and damage occur in patients, trying to develop new targets to treat. And we do know that these mitochondrial peptides, FMET, activate immune cells through a receptor called FPR1. There's a drug we can use called cyclosporin H, which blocks this specific pathway. Oh, sorry, Lesley. And what you see to the right is that we have found that serum or blood, if you would, from patients with inclusion body myositis and dermatomyositis are inflammatory. They evoke an immune response. But if we add in that system cyclosporin H, so this mitochondrial peptide inhibitor, to that system, we normalize it. We remove all of that inflammation from the peripheral blood. So we do believe that blocking this pathway, which we have shown in other diseases as well, could be helpful and a new target to consider in myopathies. So thank you, Lesley. Next, the final one. And this is just to summarize and saying that we believe that mitochondria are not only inside of cells, but they are on the go in myopathies. And we can use these mitochondrial markers in blood and tissue to help monitor disease activity, assess prognosis, and guide treatment. And we believe that targeting these mitochondria and making sure that they stay where they're supposed to do may alleviate inflammation in myopathies. And then finally, on the last slide, I would like to just acknowledge all of my team members and collaborators for all these projects, funding, and not least MIHRA and TMA for all of their support on this. Thank you.
Thank you so much, everybody. And now I'm going to hand it back over to Paula and Laurie.
Thank you so much, Lesley, and our esteemed scientists and clinicians joining us for all of those fascinating talks. Again, thank you. Let's give the docs a big round of applause. If you know how to use your Zoom reactions, you can do that, or you can clap out loud. That's great. Thank you. We will be transitioning now to focus on myositis-associated interstitial lung disease, and we will do that by sharing a very powerful story that Julia Nickerson will share. Julia is an experienced project management professional at Rakuten is her company name, where she is the director of operations, and she is the president and co-founder of the 501c3 Nori's Fight, dedicated to raising awareness, promoting early detection, and furthering advancements in treatments for anti-MDA5, DM, and ILD. And you are about to learn why Julia is so motivated in this fight. And Julia, welcome to our We Care for Rare virtual summit. Thank you so much for your collaborations with us and with MIHRA. And we're thrilled to have you. I'll turn it over to you. Thank you so much.
Thanks, Paula. Hi, everyone. My name is Julia Nickerson, and as Paula mentioned, I am the co-founder and president of Nori's Fight, a foundation created in the memory of my partner, Nori. You can go to the next slide, please. Nori was pure light. I mean, look at that smile. He lit up every room he entered. He made people feel more comfortable, and like you were the person he'd been waiting to see all day. Almost exactly a year ago, Nori was out playing what he and his friends jokingly called old man soccer. He was 42. He mentioned feeling more winded that day and that he had to take extra breaks throughout the game. That was March 2nd, 2024. Next slide. 8 days later, I took him to the ER. That shortness of breath hadn't gotten better. This rash that had appeared in late February, something we thought was a reaction to his blood pressure medication, was spreading even though we had switched meds. We left the ER that day with a pneumonia diagnosis and antibiotics. A week later, on St. Patrick's Day, we were back in the emergency room. This time, his oxygen levels were so low he had to be admitted to the hospital. Over the next few days, his oxygen dependency climbed from 2% to 30% until on March 21st, he had to be intubated. I don't know if he ever truly knew his diagnosis, anti-MDA5 dermatomyositis with rapidly progressive interstitial lung disease, unless he heard me explain it to him in his brief moments of wakefulness. We didn't get that diagnosis until April 5th, which I've since learned is considered fast for dermatomyositis, but that shouldn't be the case. Although we tried every treatment we could, I now live in a world of what ifs. What if we had gotten the diagnosis earlier? What if we had started treatment sooner? Would the outcome have been any different? After fighting so hard for over 2 months, on May 29th, Nori, someone so full of life, passed away, surrounded by his family. Next slide. Nori and I always believed that no matter how hard things get, we have a choice in how we respond. Even in our darkest moments, we can still create light. That's why, with his brother and best friend, we founded Nori's Fight, to make sure no other family has to go through what we did. Our mission is simple: to raise awareness for this disease, push for faster diagnosis, and to fight for research and better treatments. Although the world is dimmer without him, our mission now is to keep his spirit alive and light shining by sharing his story and fighting for others. We were fortunate to now have connected with the Myositis Association, MIHRA, incredible doctors, and an inspiringly resilient patient community, all of whom are helping us to carry this mission forward. Next slide.
Hello, my name is Julie Pack, and I'm an associate professor of medicine in the Division of Rheumatology at our Johns Hopkins Myositis Center. I also act as a co-director and director of clinical trials here at our center. I'm very excited to be here to discuss on Rare Disease Day, MDA5 associated dermatomyositis. It's really an honor to be here to discuss this specific disease, but I have to say it's going to be very compact and a very brief story or journey through MDA5 dermatomyositis today. So I just want to give a little bit of background that I'm sure all of you guys know, but if you don't, dermatomyositis affects about 25 to 50,000 per 100,000 in terms of the prevalence. It's a very rare disease. And we know that our patients can have multiple manifestations, including skin disease, as you can see here, with the classic Gotrin's rash or skin rash over the knuckles that can be quite itchy and sometimes painful, and also the heliotrope rash, named after the heliotrope flower, which have purple petals. So it can be almost like a purplish eyeliner-like red discoloration over the eyelids, and it can have associated swelling as well. It can also have rashes on the knees and also the Holster sign, which is on the side of the legs. And of course, dermato meaning skin rash, but also myositis meaning muscle inflammation. You can actually see a lot of muscle inflammation in some of our patients, but the spectrum is quite heterogeneous. And so to highlight this, I have this slide where you can actually have this spectrum of amyopathic dermatomyositis, meaning that you do not have any muscle involvement at all, but you have skin involvement. So this is why the skin is in pink and much bigger involvement. Then you have hypomyopathic dermatomyositis, where you actually be quite strong on exam when the physician is testing you, but then on skin exam, you still have significant rash. But if I did a deeper dive and try to look for muscle involvement with maybe an EMG, which is electromyography, an electrical test, or a muscle MRI, or muscle enzymes that you can test in the blood, we would see evidence of inflammation. And the classic dermatomyositis is where we have full-blown muscle involvement and full-blown skin involvement. Now, I think the important caveat here is that I'm talking about dermatomyositis as if it's only skin and muscle, which is not the case, especially in dermatomyositis. You will see here in this picture that, in fact, dermatomyositis can be very complicated and complex because of the fact that it can also affect the lungs and cause lung inflammation. And this is one of my patients who actually had rapidly progressive lung involvement. So specifically in MD5 dermatomyositis, you can get pretty quick lung involvement that can be quite devastating to the disease process and needs to be treated urgently. And that is why a multidisciplinary approach is very important in these rare diseases. Our patients with dermatomyositis, including MD5, can also, patients who have MD5 associated dermatomyositis, can also have calcinosis, which are calcium deposits under the skin. We think usually in areas of where there was a lot of muscle inflammation, but it could also be in multiple areas throughout underneath the skin or in the hands or in the elbows and things like this. This is something we look out for all of our patients in dermatomyositis. But I've been saying MD5, hoping that this was already discussed at some point, or you have already been learning about it, or have heard about it, but I've put it right smack in the middle here. And this slide is to highlight myositis autoantibodies. And myositis autoantibodies are biomarkers or a blood test that we can check that actually indicate to us if you are positive for this specific blood test that is called MDA5 or specific for MI2, then we know that you have dermatomyositis, most likely. Now, and in addition to that, depending on which antibody you have or autoantibody you have, we get some insights into the prognosis or the extent of organ involvement your disease may have. For example, with MDA5, we know that patients can get lung involvement and particular rashes, versus if someone else has MI2, we know that they're usually not going to get skin involvement. I mean, sorry, it's not going to get lung involvement. And these are some other autoantibodies that are known in dermatomyositis, but I'm not going to be talking about these today in detail because we know that today we're trying to highlight dermatomyositis, specifically MDA5 dermatomyositis. So again, in MDA5 dermatomyositis, one of the blessings of MDA5 dermatomyositis is that I feel that, you know, I always teach my fellows and my patients also, when I'm examining them in their hands, it's a very classic skin rash that is seen with MDA5 that has been consistently reported throughout the literature. And one of them is these kissing papules, and you can see that in these flexor areas of the hands, when you're looking at them like this, you can see that these rashes right here at the folds are almost kissing upon each other or kissing papules. And these can be quite painful, but when we have this and see this on exam, we know this is going to be MDA5 dermatomyositis. So in fact, the skin exam can be very important, especially in dermatomyositis, especially in MDA5. And as I said, interstitial lung disease or lung inflammation can occur, and it can occur quite rapidly. And another skin feature, and this is another example, that picture before was a picture of my own patient who had these kissing papules, but you can also get ulcers, which is pretty characteristic of MDA5 dermatomyositis. And it can occur over the knuckles, which can be quite painful and very difficult to treat. So in the past, now we have updated this, but in the past, we have actually looked at our entire cohort at our Johns Hopkins Myositis Center. And we found that in addition to the skin involvement and the muscle involvement, and also the classic skin rashes that I already told you about in MDA5 associated dermatomyositis, We also found that patients can get a lot of inflammation in the joints. So I think this is less appreciated, but we definitely see this where, we're so busy treating the skin and the muscle that we forget to think about if the joints as another organ, so to speak, is involved. And it's important to treat the joint involvement because it can be quite painful for our patients with a lot of joint stiffness as well. And the good news is most of our patients, over 73% actually, who had lung involvement were very responsive to immunosuppression or medications to dampen the immune system so it prevents it from fighting itself and causing more inflammation and more damage in the organs in MDA5-associated dermatomyositis. So this is a schematic of how we approach or how I approach patients who have myositis with lung disease, because I think the primary driver of morbidity in our patients with MDA5-associated dermatomyositis is interstitial lung disease. Because if it's not picked up early, it's not monitored appropriately, then our patients can sometimes actually get progressive disease and scarring, and it can be very, very difficult to manage. And so the approach to dermatomyositis treatment is largely dependent on which organ is active and which organ, is it skin, muscle, lung, or joints, that is driving the treatment tree, basically. And so in this case, if you have lung involvement, the first line medications are these that may sound familiar, like steroids or prednisone, and these mycophenolate or azathioprine. And in refractory cases, we will use tacrolimus. And IVIG is also used in conjunction with these agents if patients are not doing well. And of course, rituximab is another medication we will think about in our patients who have interstitial lung disease. So the overall breakdown or the treatment paradigm of dermatomyositis is similar to the previous one, you can see, except there's no methotrexate for those patients who have interstitial lung disease. But if you have dermatomyositis without lung involvement, you can consider these agents again. And then IVIG is here because we know it works very beautifully for the skin and also the muscle. And also rituximab works, especially in patients who have autoantibodies. And that's another reason why we would use rituximab with these other agents. And more recently, there's been a lot of interest in these newer agents, such as JAK inhibitors, which are on the market right now. There's multiple ones that are available. And currently, there is a phase 3 trial ongoing for dermatomyositis. And in addition, anti-interferon beta is another phase 3 agent that is being treated, in clinical trial right now. So hopefully, we'll hear more about these drugs as well. So the key take-home points today is that MDA5 dermatomyositis, I hope I was able to impart to you that it is a very complex disease, can affect multiple organs. And the good news is that there are multiple oral agents we can use and steroids, but we also have multiple other agents that are in the pipeline. And I forgot to mention IVIG was FDA approved for dermatomyositis, and so can be used to treat MDA5-associated dermatomyositis very effectively. And the key thing is multidisciplinary team approach, because as you can see, it could be multiple organs that are involved, and it can be challenging to treat. And that's why all the physicians, the rheumatology, pulmonary, dermatology, needs to really put their heads together for our patients with this rare disease so that we can fight it and treat it and hopefully get it into remission.
Well, I've had chill bumps and goosebumps several times during today's We Care for Rare Summit. I know I'm about to experience some more. We are about to welcome another very powerful storyteller to the virtual stage, our keynote speaker. She's pulling up her slides now. Thank you for that. Allow me to give you just a little bit of introduction, Lindsay. I want everybody to know, one second, still pulling myself together after that. Powerful story. I want everyone to know that Lindsay is an award-winning journalist, writer, producer, and podcast host whose work has been featured in the New York Times, CBS, NPR, ESPN, and many more. After being diagnosed with ADHD in 2021, an experience she calls the best thing to ever happen to her, actually, she spent 2 years learning how to navigate life with a neurodivergent brain. Then in 2023, her world shifted again with a diagnosis of dermatomyositis associated with antisynthetase syndrome. Leaning into advocacy and storytelling has been essential in Lindsay's journey of learning to live with chronic illness and dynamic physical disabilities. She is passionate about raising awareness and building community for others facing similar challenges. Lindsay is proud to partner with us, and we are proud to partner with her. And I mean by we, TMA, No Rare, the Infusion Access Foundation, and Nori's Fight, all of whom proudly partner with Lindsay to amplify patient voices, improve access to care, and drive the science forward. I spent this week with Lindsay here in Washington, D.C., and many other rare advocates as we visited legislative offices together. In every meeting, we asked for steady and robust leadership, strong federal biomedical research funding, and support for our public health agencies. These are non-negotiables. Federal agencies are essential partners to supporting timely diagnosis, conducting research, enabling therapy development, facilitating insurance coverage, and implementing public health programs. The Myositis agenda led by TMA calls for supporting their efforts, especially those of the committed scientists, clinicians, and teams at NIH's NIEHS, NIAMS, and NCATS. We stand for science now more than ever. And again, we are so glad that you are all here today because rare diseases need more research, not less. And to further illustrate why that is so important, I very happily and again very proudly pass the microphone to our keynote speaker, Lindsay Gunsell.
Thank you so much, Paula. Back in November, I was invited by the FDA and the NIH to speak at Rare Disease Day. And honestly, it was the glimmer of hope that I needed. It gave me something to look forward to, something to work towards. But a few weeks ago, like so many of you probably did as well, I started to see the writing on the wall. And when it wasn't canceled, I was honestly surprised. Of course, you all know last Friday we were notified that the two-day event had been postponed. So this is a modification of the speech that I would have given today in Bethesda. And I just want to start off by saying that I am so grateful to all of you for joining us here today. I'll be honest, over the last few weeks, I had been struggling with what I was going to say on stage. When I was first invited, I knew exactly why I was going. But somewhere along the way, that why started to shift. And it felt more like I was not just there to share my story, but to prove something. To prove that I'm worthy of care, of a future, that my health matters. Not to any of you. You already get it. You are here because you care. But outside of rooms like this, many of us feel that same creeping fear, that our lives, our worth, are up for debate. And how could we not when the very institutions that hold our hope, like the NIH, are caught in uncertainty? Funding freezes, delayed research, clinical trials on hold. For those of us living with rare diseases, those delays aren't just numbers on a budget, they're years stolen from our lives. Again, I know that I'm not speaking to any of you. You all understand what's at stake. But beyond this room, so many don't. Not until they have to. Not until it's their life that is upended. So let my rare disease story be a reminder for them. Rare can happen to anyone at any time, even to you. I joke that I always wanted to be special, that I love being the center of attention, but that all of this is a little much. And here's the thing, I really did want to be special. I know we're not supposed to admit that, especially as women. We aren't supposed to own the fact that we set high expectations for ourselves. But I wanted to be special. And I had been working really hard to get there, wherever that may be. And then all of a sudden, all of that was gone, and I was special for something that I had absolutely no control over. Something I hadn't worked for, something I didn't want. Most people don't dream of becoming a medical mystery, of becoming both the patient and the puzzle. Now remember, I wanted to be special, just not in a we have no idea what's wrong with you kind of way. But that's become my reality. For the past 2 years, I have been learning what it means to live with dermatomyositis associated with antisynthetase syndrome. It's a mouthful, I know, because it's actually 2 rare diseases for the price of 1. Because who doesn't love a bargain? Nope. Okay. Antisynthetase syndrome is an umbrella diagnosis, a complex syndrome made up of a constellation of conditions that often occur together. Think of it like a hand. Antisynthetase syndrome is the palm, and each finger represents a different symptom, like myositis, interstitial lung disease, Raynaud's phenomenon, arthritis, fever, or mechanic's hands. Some people experience more muscle issues like dermatomyositis or polymyositis, while others struggle with more lung complications. And even people with the same antibody can have different symptoms or different levels of severity. For me, my hand is filled with dermatomyositis, interstitial lung disease, mechanic's hands, Raynaud's phenomenon, and arthritis. Before I got sick, I felt like everything in my life was finally falling into place, personally, but even more so professionally. That everything I had wanted, that I had worked for, felt like it was finally within reach. And a huge part of that is because of in January of 2021, just 2 months shy of my 35th birthday, I was diagnosed with ADHD. It was like receiving answers to a question I didn't even know I was supposed to be asking. So much started to make sense. And it would be impossible for me to share my rare disease story without sharing my ADHD diagnosis story as well. Because I know without a doubt, I would not have survived these last 2 years without that diagnosis, without those answers. My rare disease story has a before and an after. One day I was healthy, or at least I thought I was healthy, and then the next day I wasn't. In January of 2023, my partner John and I were in Sedona, and I had tasked him with picking out a hike for us. A hard one, he remembers me telling him. And at some point during our 5-hour hike up and down Bear Mountain, which is the first or second hardest hike in Sedona, depending on which website you look at, I got some cactus spines in the back of my thigh. And I remember getting to the car and pulling them out and honestly not really thinking any more about it. Until the next day, because the next day I woke up looking like this. A trip to the emergency room sent me home with a big bottle of antibiotics and a cellulitis diagnosis. I flew back to Minnesota without a second thought, fully expecting it to clear up in a week or so. Except it didn't clear up. In fact, it just continued to get worse. And after weeks and weeks of appointments and extensive testing, I received my formal diagnosis on March 7th, 2023. According to the National Organization for Rare Disorders, most people with a rare disease wait an average of 5 to 7 years before receiving an accurate diagnosis. I received mine in just 2 months. Looking back through my medical records, it's clear there were so many people at Hennepin Healthcare in Minneapolis going to bat for me behind the scenes. I have to thank Dr. Buechler, the dermatology resident who I saw for my very first appointment, who saw the rashes and the roughness on my fingers and knew there was something much bigger going on. He looped in gastroenterology, who brought in rheumatology, and they were able to put the pieces together. But receiving a diagnosis quickly doesn't mean your journey will be easy. Once you have a rare disease diagnosis, your life becomes a full-time job that you didn't apply for. Although if we're being honest, the full-time job actually starts the minute the search for a diagnosis begins. Leading up to receiving my diagnosis, while my medical team worked their expertise, I worked mine. I landed my first paid journalism gig when I was 21 in college, writing for my university's daily newspaper, and I've worked as a multimedia journalist ever since. I've always been inquisitive, that undiagnosed ADHD shining through, and I used the skills that I had built over the last 15 years to dive into all of the other possibilities. As the list of potential diagnoses got shorter and shorter and worse, I clung to the possibility that there was a completely understandable explanation for what was happening to me. The new skincare line I was using, the fake nails I had just put on, the THC gummies I had been using for sleep. I even reached out to cactus researchers because how could it not be the cactus? Much to the dismay of everyone in my life who loves a good story, it wasn't the cactus. What I know now is that infection, that run-in with the cactus, it was just gasoline poured onto an already burning fire inside of me. That I had been sick for a while, and the signs were finally apparent enough for me to see. You're probably wondering, how could I not notice? When I got sick, I was in the best shape of my life. John and I were working out 4 to 5 times a week, and I was strong, like really strong. So the muscle inflammation, one so commonly associated with myositis, for me, it felt exactly the same as the aches and pains I experienced after a really intense leg day, that after workout soreness. Had the Great Cactus incident of 2023 not happened, I worry how long my disease would have stayed under the radar. Over the last 2 years, I've had more than 350 medical appointments. That's 3 appointments on a week on average. And that doesn't count the 24 days I spent in the hospital or the more than 10 emergency room visits I've had since we went on that hike. I've been poked and prodded more times than I could ever count, and I truly learned what it means to live blood draw to blood draw, as it became the only way to know how my body was responding to treatment. I've spent nearly 250 hours in infusion chairs, undergoing Rituxan, IVIG, and cyclophosphamide, a form of chemo, dealing with reactions like aseptic meningitis and allergic reactions, like the one I dealt with in September of last year that left me sick for 3.5 weeks after the infusions were over. I've traveled to donate my plasma for drug research, allowed every resident and fellow to sit in on my appointments, and have mastered the balancing act of being my own case manager, researcher, and advocate. Managing the weight loss, managing the weight gain, the hair loss from both the disease itself and the chemotherapy, dealing with the sleepless nights from the high-dose prednisone, dealing with the sleepless nights because my hands and arms would fall asleep anytime I tried to lay down. I'm not just being cute when I say my health has become my full-time job. Those rooms also became my office. Taking Zoom calls while the infusion nurse worked around me, figuring out how to finagle a recording studio out of a hospital bed, lots of pillows, and a bed sheet. It is possible. Learning how to edit out the obnoxious beeping from the IV machines from podcast episodes. Because while I had to make my health my priority, I also had a job I not only needed to do, I had a job I wanted to do, one that I absolutely loved. I've been incredibly lucky to have so many people show up for me over the last 2 years, but the unfortunate reality is, at the end of the day, all of it, all of the things I carry as a person with a rare incurable disease, it all still comes down to me. Managing my appointments, feeling the need to take the earliest available appointment, even if it completely screws up my schedule because everything feels urgent, because most of the time it is. Dealing with the insurance battles, staying up to date on which medications I need refilled and at which time, sorting out so many pharmacy errors, finding a clinical trial and finally getting in touch with the right people at the clinical trial, dealing with delay after delay. Well, finding a perfect balance of staying hopeful, but not too hopeful. Hopeful that I'll be selected, and then hopeful that it'll work. But worrying all along that you're putting all of your eggs into one basket, which, yeah, you are. You have a rare disease. You only have so many baskets. All of that has fallen to me, and it's a lot, and it can be very exhausting. Every medication I take is a gamble, not because I want it to be, but because I don't have the luxury of waiting for better options, or even the time to sit with the weight of that decision. There's no pause, no space to carefully weigh the risks, because the reality of my disease doesn't wait. I swallow pills and I sit through infusions, knowing full well that the side effects could be brutal, that the long-term risks are unknown, that almost all of these treatments weren't even designed for my disease in the first place. But when your reality is shaped by pain, fatigue, and a body that refuses to cooperate, the question isn't, what will this do to me in 10 years? It's, will this help me function today? Because I don't get the privilege of hesitation. I need to live now. I want to live now. My life, despite all of this, is pretty amazing. And the unfortunate reality is it isn't waiting for me. The future's a problem for another day if I can just get through this one. The only other person who has been affected as much as me is my partner, John. John and I have been together for 10 years, and in addition to my ADHD diagnosis, I know I wouldn't have survived these last 2 years without him. Well, I may have survived, but it would not have been pretty. Well, I've been forced to turn my entire focus to keeping myself alive. John has taken on the share of responsibilities I can no longer handle. At one point in time, he had to leave his job to stay home with me because I couldn't be left home alone. And then he formed his own business that gave him the flexibility he needed to be able to take care of me just in case the flare comes back, because we all know it's going to come back. You know, my life has been completely upended, but so has his. In a different way, sure, but we're comparing apples to oranges. I joke that I was a lot to handle, and then I got sick. But the thing is, it's kind of the truth. I am a lot, with my disease, without my disease, and I'm just so grateful that I get to do this journey, the good, the bad, and the ugly with him. He's never once made me feel like a burden, and that's truly the most beautiful gift he could ever give me. See, the thing is, there was no manual handed to us when I was first diagnosed, no guidebook or path to follow. We've just been doing the best we can with what we have at any given time. And somehow we've managed to laugh more in the last few years than the eight before that. There's this other part to living with a rare disease that I wasn't expecting. I wasn't expecting to have to work so hard to get people to believe me, to have to fight for accessibility and accommodations. See, when you have a disease that even some medical professionals have never heard of, it adds a layer of self-advocacy that some days just takes the wind out of your sails. Because when people look at me, especially right now, they don't see someone who's sick. The number of times I've been told, "But you look great." And yes, that's from medical professionals too. One of them even considered an expert on my illness. That's the thing about invisible illnesses. You're constantly performing for those around you. You choose your words carefully and you become an expert at describing things with an intense amount of detail because you have to. You find yourself explaining why you need your cane, why you're using your scooter one day and walking the next. You're watching people do the mental math, trying to decide if they believe you. It's important to remember that people love a good recovery story. They love the idea that you fight and you win and then you get better. But what happens when getting better isn't an option? What happens when the best case scenario isn't remission, but simply management? I live in that gray area. I have an incurable disease that can flare up at any time. Over the past 2 years, I've rebuilt some of the 25 pounds of muscle I've lost, only to lose it and rebuild it again, and again, and again. And that's going to continue to happen. I spent last summer relearning how to sit up on my own, not a normal activity for a 38-year-old woman. And here's the truth I do have to face. I will never be the person I was before I got sick. But I'm still here, and every single day I fight to be seen, to be heard, to make sure the people who come after me don't have to fight this hard. We need funding for research. We need doctors trained to recognize rare diseases. We need healthcare systems that work for patients, not against them. Because the simple fact is, rare disease is not rare. I think it needs a marketing overhaul, if I'm being honest, because that word rare just throws people off. There are 300 million of us worldwide. That's nearly the entire population of the United States. See, getting diagnosed with ADHD gave me this roadmap for understanding myself. But getting diagnosed with a rare disease truly taught me how to survive. And through it all, I've learned that resilience isn't just about pushing through, it's about knowing when to ask for help. Now, in my original speech, I had planned to share a lot about the relationship that I've built with Julia Nickerson over the last few months. But Julia, in this impromptu day that we have thrown together, got to share her story here, and I'm so proud of her. But one of the things that I wanted to share is I joke that every single person that I've met on this journey is somebody that I would spend time with in real life, even if I wasn't sick. And that's the truth, because it is such a special community. And whether you are here as a patient, as a caregiver, as a family member, as a friend, I know I have a lot of people in the audience right now, and my goodness, does that just mean the world to me, because I wouldn't have made it through these last 2 years without all of you. And I love the people that I've been able to introduce into my life because of this. And I'm not one of those everything happens for a reason kind of people, but despite everything, I'm really enjoying where I'm at in life right now. And I hope you all feel a little more seen after that. I hope all of your struggles feel a little more held up by the rest of us. We have to be a community because the days are so hard that if we don't, it's just going to be impossible. So thank you all for joining us. Thank you all for being here, for being so supportive these last few weeks. It has been a whirlwind, but I got to tell you, on Friday, after we got the news, that was 11 a.m. This event was planned by 5 p.m. So I will say something. Do not light a fire under a group of people that you do not want to make change, because it will happen. So thank you guys so much.
Wow, thank you, Lindsay. Big round of applause. So much love coming your way in the chat. I definitely want to say today, Lindsay, you are seen, you are heard. All of you are seen and all of you are heard. And we will continue to walk this walk with you. It's very difficult to transition out of these just heart-wrenching stories. But I do want to pick up the final just few minutes of the program here while we're all together at the We Care for Rare virtual summit celebrating myositis science and patient stories. I'm going to screen share just a couple more slides here as we bring it home. You know, eventually I will screen share them. Here we come. Okay, so again, thank you to Lindsay for that presentation. And I just want to underscore, I really wish we had been able to be together on the campus of America's Research Hospital at NIH for that testimony. Just like the myositis science posters that we virtualized earlier, being together on Zoom is the next best thing. And we're really grateful that each of you joined us today. And I just want to harken back to the myositis agenda. We'll put a link in the chat, but it's so important that we come together, as Lindsay illustrated, to support the scientists, clinicians, and teams that are advancing our knowledge, as we touched on. We're also advocating for the reauthorization of the Rare Pediatric Disease Priority Review Voucher Program and the Accelerating Kids Access to Care Act. These efforts have been supported with broad, even unanimous support in past Congresses, and these are very important initiatives to our JM families and our Cure JM Foundation friends. Speaking of additional nonprofit friends, TMA urges continued productive nonprofit partnerships with federal agencies, including NIH and FDA. Families work with private nonprofit organizations like ours. At TMA, we fill critical research funding gaps, and this can be a win. Private funding can significantly supplement federal appropriations and enhance government efficiency. We, with all of you, want to bring about a better research ecosystem with policies that incentivize rare drug development, noting again the importance here of incentives like priority review, vouchers, the Orphan Drug Act, but also allowing industry to innovate more easily on clinical trial design. In myositis, we'd love to have trials that evaluate outcome measures that actually reflect clinician experience and patient priorities. And finally, the myositis agenda led by TMA calls for expanding access to therapies and potential treatments. And so thank you to Lindsay and John, not just for sharing today, but also for standing with us in the halls of our federal buildings on Capitol Hill to bring these priorities front and center in front of our legislative decision makers. And all of you can help us in this work by contributing to TMA's giving campaign on Rare Disease Day. We are seeking to raise $5,000 from 50 donors for TMA's scholarship fund. We know that attending TMA's patient conference now in its 30th year can be a transformative and life-changing experience. Many of you on the call have shared that, in fact, that was your exact experience at the conference. So if you have the means to give back, we would certainly appreciate that, and we'll put the link in the chat. Now it is my pleasure to welcome a colleague from NORD for some closing remarks, and I'm going to throw it all the way back before we wrap up for the day by reflecting on the year 1993. Zoom was barely a glimmer in anyone's eye at that time, I think, but that is when TMA was founded by the woman you see on the screen, Betty Curry, living with inclusion body myositis. And she established TMA with NORD's help. Together, they pulled together a list of 16 patients. We had, gosh, about 25 times that number just here today at the We Care for Rare Summit. And so we're really grateful to NORD for supporting TMA's origins 32 years ago. We've been a proud NORD member ever since, and we're very proud today to welcome NORD's Director of Membership, Allie Ward, who has been with us during the summit and will share some closing remarks. Allie, thank you so much for being with us. Over to you.
Well, thank you, Paula. This has been a wonderful day. This is so many powerful messages from Lindsay and others, and a tough one to follow. I am just honored to be here today and have the opportunity to wrap up this impactful afternoon. As we heard many times today, more than 30 million people in the US are living with rare diseases. There are 300 million people worldwide. 1 in 10 Americans are living with rare diseases. But these are not just numbers, these are people. NORD is the US sponsor of the Rare Disease Day, and the goal of Rare Disease Day is to bring awareness to this important community. One thing that resonated with me today, Dr. Machado said, rare is more than just a number. Rare is a superpower. As a cancer survivor, I often felt like I was just one of millions with cancer. How could I possibly make a difference as just one person? NORD's tagline is "Alone we are rare, together we are strong." Today, with this event, the myositis community on Rare Disease Day is bringing together the voices of the rare community. All patients, caregivers, and those that advocate for this community are part of a movement. The 50 to 70,000 people with myositis can join the entire rare disease community to amplify our voices and affect real change. Your voice and your story matters. On the NORD website, we have a section for Faces of Rare, and we want you to share your pictures to show that you are living with a rare disease. We just launched a program available to our member organizations to help the community advocate and affect policy on the state and federal level. The Cura Advocacy Academy is a 90-minute course that shares how you as one person can advocate for more research and bring the needs of this community to life. The Cura Advocacy Academy is available to all of the myositis community. You will get links to the NORD website and the Cura Advocacy Academy in follow-up emails. We want everyone to take advantage of this resource that is being offered to members of our community. Today, we heard from investigators who are dedicated to this community. Patients and care partners shared their experiences and the effects of living with a rare disease. It is very important that we continue to share our stories and show that our experiences are important. This will not only affect those with rare diseases, but will help everyone with a medical condition. Again, alone we are rare, together we are strong. Thank you so much.
Thank you, Allie. Very well said. And again, we so appreciate the partnership with NORD and everything that you and your colleagues do to support those of us in rare. Many hundreds of organizations belong to NORD, representing more than 7,000 rare diseases. And it's days like today, Rare Disease Day, that give us a focal point to bring more attention to all of us and to what we experience. So thank you all so much for attending today's We Care for Rare Summit, celebrating myositis science and patient stories on Rare Disease Day. I will be carrying today in my heart for the days, weeks, and months to come in our work at TMA, at MIHRA, and at Nori's Fight. We will remember all of you and continue to work very hard on behalf of you. While we may be wrapping up the official part of the program, if you will, our zebras are going to be trotting over to grab their favorite beverage. I may be having a glass of white wine, but you may have a sparkling water or anything that you like. And we will continue into our virtual happy hour time. So I will ask Rachel to share any additional announcements or to-dos as we close out. The virtual happy hour is right here. So if you want to keep hanging, stay here. If you would like to depart from us, that is fine. You can depart the herd or the dazzle. Rachel, are you here? There you are.
Yeah, I am here. And yes, please take a quick break. Go to the loo if you need to, grab a coffee or a tea or whatever. But we are going to talk about what we have all experienced together and just have a good time. So we will get started in about 5 to 10 minutes.